Good afternoon, and thank you for attending this month's OCHIN Grand Rounds. In honor of Cervical Health Awareness Month and through the collaboration with the Bridge C2 Center out of Oregon Health and Science University, we are excited to host Dr. Amy Weiser of OHSU as she presents an overview of the 2019 ASCCP Risk-Based Consensus Management Guidelines. Dr. Amy Weiser is an educator, mom, and wife who practices full-scope family medicine at OHSU. After residency, she completed a fellowship focusing on high-risk obstetrics and surgical delivery. Her clinical passion is providing comprehensive maternity and gynecologic healthcare. Originally from the East Coast, she started her practice in a rural Oregon community and then moved to Portland to pursue academic medicine. Dr. Weiser is one of the few family doctors in the nation to hold C-section privileges at a university hospital. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the chat box. This presentation will last approximately 50 minutes with 5 to 10 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Amy Weiser to present an overview of the 2019 ASCCP Risk-Based Consensus Management Guidelines. Dr. Weiser, the floor is yours.
Thank you so much, William. I'm going to go ahead and share my screen. Okay, so this should be the same overview screen that you had seen during William's lovely introduction. Thank you so much. So hello and welcome everyone, my friends and my colleagues. My name is Amy Weiser. I use she, her pronouns, and I'm a family doctor in Portland, Oregon. Thanks for joining me today. Today is quite a momentous day in many regards, and so sharing some time with me, I really do appreciate. And I'm really excited to share an overview of the 2019 ASCCP Risk-Based Consensus Management Guidelines with you today. The title of this is a little bit lengthy, and so I'll probably refer to this as the 2019 Risk-Based Guidelines to shorten it up just a little bit. Moving forward, I have no financial conflict of interest to share, but I would like to share that I hold several roles within the ASCCP. I'm on the board of directors. I am also graciously appointed director of our National CME Comprehensive Colposcopy course currently, and I served as content expert representing the ASCCP during the development of these new risk-based consensus guidelines. So our objectives over this lunchtime hour, and really what I aim to share today is the following. I want to review the evidence used to develop these new risk-based guidelines. Where did they come from? Review the risk thresholds, which we'll talk about in a little bit, and how we use these to determine our clinical action or our management strategy with our patients, as well as to demonstrate the new technology, i.e. the app, that providers are going to be using in a clinical context. So these guidelines, so the 2019 ASCCP Risk-Based Management Consensus Guidelines for abnormal cervical cancer screening tests and cancer precursors, actually there's an even longer proper name of these, were published in April of 2020 in the Journal of Lower Genital Tract Disease. And the publication included the main article as well as 7 supporting articles. And these guidelines replace the 2012 ASCCP guidelines, which on the clinical side, many may be used to using. And these are something that we usually will have these algorithms because they're algorithm based. They'll be posted somewhere in your office. Some offices even have these laminated. But the 2019 guidelines are going to replace the 2012. So change is hard, I understand. Absolutely. After a year of COVID and changing protocols, it would, for what seemed like every day, I totally understand that we are fatigued with change. But let's just explore why these changes were needed, the thought process behind this paradigm shift, and move from there. So as we start our discussion, let's just reflect on why the guidelines were updated. This is not something that, oh, there was a guideline written in 2001 and then it was updated in 2006 and then 2012, which actually it was. And so, oh, 2019, we were due for it. Well, there's a little bit more to it. It was really updated to accommodate the 3 available methods of cervical cancer screening that we have in this country. So we have cervical cytology alone, which is simply the pap smear. And many of you out there may have had a pap smear in the past. And many other providers who may be listening had probably started my career using this, and many of us even still use just this method. There's also the method of co-testing, so using cervical cytology, so your pap, with HPV testing. And this is likely becoming more of the typical way that we screen for cervical cancer. It's probably more common to some of you now. And then there's primary human papillomavirus or HPV screening. And, honestly, I don't know of anyone or any institution who is using this form of screening. There's a lot of research. There's a lot of speculation about being able to use this as self-swabbing in developing countries, as well as within our own. But for purposes of clinical medicine, we don't typically see this, but it's out there. So if providers are using different methods of screening, then how do you determine next steps in care if you have abnormal results? And really this underlines the development of these new guidelines, which are now based on risk, not just result, but more risk-based. And please note that that abnormal results are discussed in these guidelines. So the guidelines, these particular guidelines do not cover screening in and of itself. So if you could kindly refer to the U.S. Preventative Services Task Force and the American, the ACS for review of screening guidelines, that would be probably most beneficial. How are these guidelines updated, developed, and finalized? So thinking about the WHO and who participated in this. So the ASCCP actually utilized a very thoughtful stakeholder or consensus approach to the development of the guidelines. The list on the left may be very familiar in terms of which medical societies you might recognize. The CDC and National Cancer Institute, the NCI, were also involved, and they're listed under our federal agencies heading. The division of NIH, which is NCI, is a fantastic and longstanding research partner of the ASCCP. And notably, I'm going to draw your attention to the upper right-hand portion of the screen, is that 4 patient advocacy groups were included in the consensus process and played a major role in providing the patient's perspective to the process, which is a bit of a newer theme, including advocacy organizations over an 18-month process to begin with. So now that we know who had representatives at the table to determine and develop these guidelines, I want to just talk about the data that were used. So the Kaiser Permanente Northern California, or KPNC data, were used in the guideline development. And the data includes over 1.5 million women with routine testing, co-testing, from the years 2003 to 2017. It also includes HPV genotyping results for approximately 19,000 patients. And truly, it's the largest and longest real clinical experience with HPV-based screening in the world. The follow-up length of this data contributed to risk-based evidence, allowing for use of past history and a more personalized management of results to really transform these new guidelines. So in taking a look at KPNC data, how do we know that this data is representative? KPNC is generally a very well-screened population with cervical cancer rates that are lower than the national average. So we wanted to compare the risks and risk-based management from this population to that of other large cohorts or trials. And we wanted to make sure that the data was representative of the nation as a whole. And so we compared KPNC data to other published or accessible cohorts. So namely the New Mexico HPV PAP registry, which is a published previous study and included data points for about 450,000 people. Also, the CDC has a National Breast and Cervical Cancer Early Detection Program. And they actually have 2 arms. One is a well-screened population of those with a cervix. About 200,000 data points are included in this arm. And then there's an almost similar sized version of data points for people who are rarely screened, or maybe they've never been screened, or maybe we just don't know what their history may have been. And then additionally, the BD Clarity trial, which has about 30,000 data points, including those with genotyping. So before we move further on, I am going to kind of change gears a little bit. So before we get into the validation and continue further discussion, I think we need to interject a quick primer and terminology just to center all of us, to get us all on the same page. And the nomenclature is about the pap smear result. So when we do a pap smear cervical cytology, we see the following results. We can see nilum, which is negative for intraepithelial lesion or malignancy. So this is a normal result. So if you've ever done a pap or have had a pap and somebody said, hey, the result is normal, this is really what they're meaning, although the nomenclature is a little bit lengthier that we get from our pathology colleagues. So that's normal. And then we have low-grade cytology, and this includes ASCCP. Lots of letters are going to be floating on the screen, bear with me. ASCCP, which is atypical squamous cells of undetermined significance, so slightly abnormal, but we're just not quite sure of the significance. What does this mean? And then there's a low-grade squamous intraepithelial lesion. And so this is a more definitive, yes, there is an abnormality. We're seeing some different histology under the microscope. And so this is a low-grade result. And then we're going to counter this with high-grade cytology results. So this includes high-grade squamous intraepithelial lesions. It also includes atypical squamous cells -H, so ASCH. So now there's atypical squamous cells, but gosh, it's beyond undetermined significance. Now we're a little concerned, but we can't quite exclude high-risk findings. And then the last two items would be atypical glandular cells, AGC or AIS, which is adenocarcinoma in situ. And these would be very high-risk findings as well. In follow-up to an abnormal result, we collect a biopsy, so a tissue biopsy during a colposcopy in follow-up to this. And these results are then grossly categorized a bit similarly. There's low-grade cervical intraepithelial neoplasia, or CIN1. And then more importantly, and listed on this slide, is CIN2 and CIN3+. So CIN2 and CIN3 are both high grade. CIN2+, for the purpose of the publication, this term included CIN2, CIN3, AIS, as we mentioned, as well as frank cervical cancer. And then CIN3+ includes CIN3, AIS, and cancer. Histologically, and our pathology colleagues will agree that a lot of times it's very hard to distinguish between CIN2 and CIN3. So sometimes they get lumped together, and generally speaking, we're talking about high-grade findings on biopsy. Okay. All right, so we've just rattled off many, many letters, but we're talking about normal, low-grade, high-grade, and then our follow-up histopathology. So coming back to our validation of results here. For illustration, we're going to look at the previous study, which found a 5-year risk of CIN3+, or the high-grade cervical dysplasia that I mentioned, in both the Kaiser dataset and New Mexico registry to be pretty similar. And this graph is from the Gage paper that was published in 2016. So the comparison is limited to an extent because these are all cytology-based results, except for when it's marked HPV positive and HPV negative ASCCP. A lot of times HPV is not, earlier on in the data set, in the history, HPV was not empirically drawn or reflexed out, clinically speaking, unless there was an ASCCP finding. Okay, so the solid lines in the graph are New Mexico population, the dashed lines is a KPNC, and the lines demonstrate the risk for these various cytologic and some HPV combinations. And we know that there's general agreement between the two populations. Now, there is an exception of LSIL, which is that dark coloration, it's black on the screen at the 50 to 64 year age range. So we do realize that this is not perfect, but generally speaking, statistically speaking, there's enough similarity to say that the KPNC data, the data set that has been used to develop the guidelines, is really representative of other maybe less well-screened populations that do have a higher rate of cervical cancer here within our nation. Okay, so we have the people who was at the table. many tables because we've met multiple times, and many phone calls virtually like we're doing now, as well as what data did we use. Now we're going to talk about which risk factors influence precancer development. So on this screen, we're just representing some of the things that the consensus process for the guidelines included when they evaluated risk factors to determine what should be used when we're talking about risk determination of CIN2+ or that high-grade finding. So the bar graph demonstrates that while there are known risk factors for cervical dysplasia, such as smoking, such as age, such as race and ethnicity, and I realize that these are grouped, that these are two different things, but on this bar graph they are one. So we're just going to acknowledge and roll with that. But what we see is that really only cytology as well as HPV type have a strong enough influence to be incorporated into the guidelines at this time. Okay. What is not yet incorporated into the guidelines, but is very important, is HPV vaccination. And the risk group that was part of the consensus process considered vaccination history very carefully. While it's clear that HPV vaccination before the age of 18 reduces the CIN3+ risk by 50% and is very important, several factors were considered, one of which our national rate of age-eligible first dose vaccine population coverage is pretty paltry. It's only about 50%. This was from a study that was published in 2015. More recent data says maybe it's about 64%, and those are some data points from the CDC. Even still, it's not really great. We can do a lot better. So it's very hard to take into account HPV vaccination when maybe only half or slightly more than half of the eligible population are actually receiving this coverage. Poor records, as well as a lack of a national vaccine registry, are also barriers. So typically, guidelines haven't included factors that clinicians can't document. And the medical record, though it has lots of information, may not actually hold the data points of when and where and what vaccine somebody received. So these are definitely barriers. For now, it's anticipated that future data on vaccination in the US is going to improve. It's going to become more robust. And with that, then at that time, vaccination history will be incorporated into the risk-based guidelines. But for now, though we recognize that that HPV vaccine is extremely important, they are not yet included. So this brings us to fundamental concept number one. As we think about this background, we know that the longer an HPV infection has been present, the higher the risk of both precancer and cancer. So from this, what we understand from the science is that time matters for an HPV infection as well as type. We know that HPV-16 subtype is the most dangerous as far as talking about risk and development of cervical dysplasia. So the clinical correlate that is a fundamental concept of the guidelines is that colposcopy is always needed following 2 consecutive positive HPV tests. So the longer the person has a positive HPV, the more at risk the person becomes. And we can look at this in a graphic form. So looking at the diagram, time being on the x-axis and HPV infection on the y, over a 3-year period of time, the majority of HPV infections are going to clear. And this is represented by the green portion. Yay, the big green portion on this graph. But some infections are going to persist, and this is represented by the yellow. And then some infections are going to progress, and this is that band of pink at the very top of the graph. So though HPV infections, majority of them are going to become undetectable between 1 and 3 years, those that persist can go on to cause CIN3+ over time. And so we've kind of taken that pink portion of the graph that we just saw, and we expanded and we enlarged it, and now it's on the right-hand side. So it illustrates, this new graph illustrates that for those progressing HPV infections, invasion or cancer occurs in 30% of cases in 10 years' time. So from this, we know that when infections persist for 5 years or more, precancer and cancer increased markedly. But kind of bringing it back to what we do in a clinical setting, we know that screening distinguishes normal from abnormal. We know that a colposcopy with biopsy, we take a sample that'll help us to detect CIN3 or that precancer. We know that treating CIN3 is going to prevent cancer. So really the goal of our screening is to detect CIN3 and prevent cervical cancer. Fundamental concept number 2 of the 2019 risk-based guidelines is a big one. Management is now based on risk and not results. So recommendations of colposcopy or treatment or surveillance are based on a patient's risk of CIN3+ determined by a combination of their current results as well as their past history. And this can include not even having a history or not knowing a history. The past history that we're talking about is the one that was most recent, so the one immediately prior. We're not talking about the most severe results. We're talking about the one that was most recent. And this gives rise to the same current test results between two individuals may yield different management recommendations depending on the history of the recent and the past test results and other risk factors. So this is one of the primary concepts of the 2019 consensus process. We're basing care based upon risk when available, rather than a specific combination of tests. This is a huge paradigm shift from the 2012 guidelines that we've been using. So we say that past history influences current risk, okay? So let's do an example. We have a patient who has an ASCCP, which is a low grade, but HPV positive current result. So what is our immediate risk of CIN3+ if we take this and then include prior results that a patient may have had? So if prior to the ASCCP HPV positive result, someone has a negative co-testing, so a normal pap cervical cytology and a negative HPV screen, we're looking at the blue bar on the left-hand side of the screen. The management recommendation is to co-test them again in a year, to bring them back in a year for surveillance. This is going to be in comparison to the recommendation for colposcopy for those who may have an unknown history, a history of NILM, so a normal cytology, but HPV positive results, or a history of treatment, and these are seen on the bars demonstrated in yellow. So why is this? The recommendation is based on the newly established threshold for colposcopy, which is when an immediate risk of CIN3+ equals or exceeds 4%. We're now moving to colposcopy, and the data supports this change to threshold. So this is a diagram that has been taken directly from the main article and demonstrates the thought process for risk-based management specifically. The first decision is based on immediate risk of CIN3+. So if the immediate risk is above 4%, then further management is based on a specific clinical action threshold. And this shoots us to the upper right-hand portion of this diagram. If the immediate risk of CIN3+ is below 4%, then the type of surveillance versus management is based on an equally important specific clinical action threshold. And so you would follow this algorithm to the bottom right-hand side. What does this mean? Well, the new guidelines triage high-risk patients to treatment. They avoid unnecessary tests for lower risk individuals, and they'll be enduring because they're based on these clinical action thresholds and not specific test combinations. So this is a constant in a landscape of changing test options and decreasing HPV prevalence due to increase of vaccination. So remember, our decision to action is now risk-based, it's not plainly result-based. Now, the risk-based guidelines do include some concepts that we already knew and still will use from the 2012 guidelines, but these are now better defined. Histologic H-cell or CIN2+ on biopsy remains the threshold for treatment in the general population. We know that CIN3 should always be treated except in a case of pregnancy. And that CIN2 now has the option of treatment or observation with colposcopy and biopsy for those concerned with treatment effects on future pregnancy. We are now specifically including reproductive goals in our formulation of treatment strategy and in our shared decision making. Likewise, we're now defining high risk individuals to focus resources. So this is an example of a very high risk individual based on these results. They have an HSIL, which is a high grade finding on their cytology. Their HPV is positive, and we know the type, it's 16. This represents really the highest immediate risk of CIN3+, with a greater than 75% risk of any precancer and a greater than 60% risk of highest grade precancer, CIN3+. And based on this risk, expedited treatment is the preferred recommendation. So this slide introduces the term expedited treatment or excisional treatment for patients at high risk of precancer. And this is done without requiring a confirmatory biopsy. This is a new term in the 2019 guidelines. So expedited treatment, or see and treat is sometimes what we call it, is preferred in some cases. I think about this when access to care may be a factor. So if you lived in a non-ACA state, if you had a patient who was seeing because they were pregnant and they had insurance because of that pregnancy, postpartum, they're going to lose their insurance, or it's going to term out, access to care may be a factor. And it's a way to really streamline this process. So there's no extra trip in for the colposcopy that can be eliminated. Wait time for pathology results can be eliminated as well. I think that there are certain patients and populations where this might be most beneficial. But again, this is something that, and I cannot stress this enough, having a shared decision-making conversation with your patient is also very, very important. Though expedited treatment may be preferred, going through colposcopy, biopsy, and confirming those results before having a treatment is also acceptable. And so this brings us to our next slide. It represents the clinical action thresholds. Really, we're talking about that CIN3+ immediate risk for expedited treatment. And it covers various management options for any patient who has an immediate risk of CIN3+ of greater than 25%. So if a person comes in and it's calculated that their risk is greater than 25%, colposcopy or expedited treatment is acceptable, as I had mentioned. And for anyone with a risk of greater than 60%, expedited treatment is preferred. So we're really focusing on resources for high-risk patients. Other key changes in the 2019 guidelines include excisional treatment being preferred to ablative treatment. So excisional treatment preference was based on a review of unpublished data that demonstrated that the majority of treatment in the US was excisional and provides a reduction in recurrence of high grade as these patients are longitudinally followed. So an excision can be referred to as a LEEP, which is an in-office procedure. I'm one of the providers here in family medicine that does them, or a little bit more intensive, meaning a little bit more training and referral to our OBGYN colleagues for something called a cold knife comb. But these are excisional therapies. This in comparison to ablative, which would be a freezing, so cryotherapy or a laser therapy. Moving on to the other bullet on the slide, observation is preferred to treatment for CIN1. So if someone has persistent CIN1 or that low grade pathology finding, treatment should include a shared decision-making conversation based on reproductive goals, of course. But of note, this co-testing colpo cycle that some of our patients get stuck in will hopefully change based on the new guidelines. And so treatment for persistent CIN1 will hopefully come up less commonly. Other key changes. So after treatment of high-grade CIN2-3, so after excisional treatment, HPV-based testing is recommended now at a 6-month interval and then annually for 3 years. And this is a change from the 2012 guidelines. As well as continued surveillance. So HPV testing or co-testing at 3-year intervals after the aforementioned annual test for 3 years. You then extend to an every 3-year interval. Continues for at least 25 years. This change is important because primary care folks need to be aware of this. After a LEEP, patients typically are going to be followed by their PCPs, so we need to continue closer surveillance for our patients who post-treatment remain at a higher risk threshold. Okay, going back to, again, to the main paper diagram to now focus on the immediate CIN3 plus risk falling between 4 and 24%. So we talked about greater than 25%. Now we're going to talk about 4 to 24% immediate CIN3 plus risk. So this is really the meat and the matter, this colposcopy threshold. So based on prior history and current results, an immediate risk of CIN3 plus 4% or greater is going to yield referral to a colposcopy. Now, no, this is less than the 2012 ELSO associated risk of CIN3 plus of 5.2%, which then prompted recommendation to colposcopy up until this point. So this is a change. So due to this, there may be an initial increase in the recommendation of colposcopy for those having their initial screen. But what about those with prior results? So this is a very busy slide. I do recognize this, but let's talk about this together, because this slide demonstrates the impact of a prior negative HPV test. So if we look at midway through this graph, the ELSO HPV positive and ASCCP HPV positive results, these red numbers, we're going to focus on those. So if you don't have a history of a prior negative HPV test, we're going to look at the right of the big green arrow. The colposcopy threshold is going to be reached for these results as immediate CIN3 plus risk is greater than 4%. So 4.27% and 4.45% respectively. So without having anything prior, the immediate risk is going to surpass that colposcopy threshold. And these patients are going to need to come in for further evaluation and procedure. And compare this to a significantly reduced risk for the same results when it's preceded by a negative HPV test. Now we're taking a look to the left of the big green arrow. With the calculated risk of 2.1 and 2.03%, these results now yield a recommendation for a 1-year co-test follow-up. So knowing history and so determining risk can yield fewer needed colposcopy procedures, which is fantastic. Also, we know that the impact of HPV typing, specifically, as I had mentioned before in that example, HPV 16, does have quite a bit of impact on risk. So as we just reviewed, the ASCCP HPV positive or ELSO HPV positive result preceded by a negative HPV, the immediate risk of CIN3 plus would be below the colpo threshold. We would have them come back in a year. But in this scenario, type-specific testing will raise that risk above the colpo threshold. So for this, we would see that if we knew that HPV type to be 16 positive, the risks associated are identified at 5.34% and 6.7% respectively. And so this would yield a move to colposcopy as follow-up based upon this risk. Further advancement in type-specific testing will allow additional HPV types to subsequently be added to the guidelines. And so we'll have a bit more finessed specific management style. So the tables that I use on this slide and the prior are available on the NIH website, and there is an online decision-making aid as well there. However, these graphs and tables take a long time to get used to reading, and 18 months of the development process, actually. And so we're not expecting clinicians to pull up big graphs that I may have had in my kitchen for a period of time to look and to figure out risk. It's just not an efficient way of doing this. So there is an app that was made, and the ASCCP had an app for the 2012 guidelines. This is a new app because software with this data set just could not be upgraded in a fashion that supported it. The app is a little bit more streamlined and can be absolutely used in the office setting. I use it all the time. And we're going to circle back on that in a bit and do some examples. I do want to note that special circumstances, of course, in medicine always come up, and HPV 18, HPV negative by AGC, and ASCH are a few situations where risk level for CIN3 plus doesn't really reflect the risk for cervical cancer, and as a result, these are considered special circumstances and require a more conservative approach in management. So key guidelines for the 2019 guidelines, or excuse me, key changes in the 2019 guidelines, colposcopy can be deferred for certain patients. So repeat HPV testing or co-testing in a year is recommended for patients with minor screening abnormalities indicating HPV infection, but with a low risk of underlying CIN3+. So we're going to shift back to the diagram again, just to center ourselves. And now we're going to focus on the surveillance action thresholds. And these are utilized when the immediate CN3 plus risk is less than 4%. And in this situation, we then turn actually to the 5-year CN3 plus risk to determine management. Determining surveillance intervals, truly, although at this point in the talk you may not believe me, we did wish to provide simplicity. We know that providers are familiar with follow-up intervals of 1 year, 3 year, and 5 year, and we really had no compelling reason to change these intervals based on our data sets. And we also know that health systems and tracking features are built around these intervals as well. And so we decided to keep these status and not change them. So the 5-year return, the guideline, really the risk should be similar to that of a negative HPV test or co-test in a screening population. So if an estimated 5-year CN3 plus risk is less than 0.15%, this is a person who, based on the risk, can return to, it's just a routine screening at 5-year intervals using HPV-based testing, okay? We can then compare this to a 3-year return, and really the risk should be similar to that of simply and solely a negative PAP test in a screening population. So when patients have an estimated 5-year risk that exceeds that of the 5-year return that is less than 0.55, then we're going to have them come back in for repeat testing in 3 years with HPV-based testing. This is recommended. There are other guidelines and stipulations if you do not have HPV-based testing. So the 3-year, kind of between the 1 and the 5-year interval cutoffs, right? So examples of this. So if you have an HPV negative LSIL that's followed by, I'm doing the second line, that is followed by an HPV negative NILM, this leads to a really low immediate risk. And in this case, the 5-year risk is 0.40. And by our risk calculator, it results in a 3-year follow-up. So this would be an example of someone who cannot yet get back to that 5-year screening, but at the same time isn't low enough risk, or excuse me, is not high enough risk to denote the need to screen yearly, which is what we're going to talk about next. So the 1-year return. So when a patient has an estimated risk, CN3 plus, that's below the threshold for immediate colposcopy, so less than a 4% immediate risk, but above the 3-year follow-up threshold, this is a person who we're going to invite back in a year to have HPV-based co-testing as follow-up. And examples of this, if someone came in and had a normal PAP and an HPV positive finding, their CIN3 plus immediate risk is not going to exceed that 4%, but their 5-year CIN3 plus risk is going to exceed 0.55%. And so they would fall in this 1-year follow-up category. Okay. So I realize that this can be complicated, and if you don't do this every day and literally dream of this stuff, which sometimes that happens to me, that you might be a little confused and a little overwhelmed. So I wanted to end our session by demonstrating the app. It's a new app. It was released in June of 2020. It costs about $10. Okay, there is a fee to it. And I kind of think of this as a trip to Starbucks, right? It's not an outrageous fee. And as I mentioned before, the old app just couldn't be upgraded to this, though we tried. Moving from a result-based to risk-based software, it just wasn't feasible. Also, it has come up in conversation about integrating these guidelines in this app or a decision aid into the EMR. But as I have learned, that is quite cost prohibitive. It would greatly exceed any budget that the ASCCP would have, although that is an element of integration for the future that we would hope for. But for right now, we're on an app, or you can use the NIH tables. But I wanted to just show you a couple of screenshots to get you familiar clinically of how this could be used. So let's start with a scenario. Say a 32-year-old person presents for routine cervical cancer screening. No history of cervical cancer screening, has never had this before. And you would say, gosh, does this really happen? And I would say, yes, it does. So not outlandish as a scenario. The Results of the current co-testing that you just did, the cytology and HPV testing, provides you the following information. Their cytology is ASCCP, so low-grade finding, but abnormal, and their HPV is positive. Okay, we don't have the serotyping here or the genotyping here. We just know if it's positive or negative. So this would be what you would use when you're inputting data into the app. And so on the left-hand side, you see that we're in clinical situation. We check the age criterion or the age range. So this person's 32. You just click on the 30 to 65 years age range. And then clinical situation, we are managing just routine screening results, right? This person doesn't have history of anything else, has actually never had a screen. And so this is the clinical situation that we are focusing on. The next screen, it'll ask us to input current testing. Our HPV is positive, but it's untyped. We don't have the genotype. And our cytology, and it actually gives us these little lovely icons to think about as well. So ask us, okay? And then it says, does the patient have previous screening test results? And from our patient, no, we don't have any. So we would click no. This then takes us to a confirmation screen to make sure that we hit all the right buttons, essentially. So again, we have confirmed management of somebody falling between the ages of 30 and 65 with a co-test presenting with positive HPV and ASCCP. So then we'd hit next and get to the next screen, which would give us a recommendation. And the recommendation of care for this patient is colposcopy. And this is because the immediate risk of CIN3+ for this patient is greater than 4%. We have surpassed that threshold. Actually, the patient's risk is 4.4%. And so you can see how one would use the app. And it's a lot quicker, it's a lot easier than using all of the Excel sheets that are available, but a little bit more cumbersome. So this patient would go for colposcopy. Let's do another scenario. And so this patient is 36, presents for routine cervical cancer screening, so similar to our first patient of the day. Now, this patient does have prior results, has had screening before. So screening results in past have been normal or nilum and HPV negative. The results of this person's co-testing is interestingly and surprisingly exactly the same as the one that we just went through. So cytology is going to be ASCCP, HPV is going to be positive. And we move to the app, same age range, same management of routine screening results. And then we get to current testing. Oh, it's the same results as last time. So positive HPV, it's untyped, cytology is ASCCP. And now here's the change. Does the patient have previous screening test results? Yeah, they actually do. So it brings us to a new screen. And again, this is just kind of screenshotted down here. So after you hit yes, it'll say, well, input the data. So prior testing, what was the prior testing? This person had a negative HPV and a normal cytology in the past. Does the patient have other previous screening test results? No, not that you can find, it's not documented on the chart. Again, it brings us to the confirmation screen, making sure you hit all the right buttons and have the right clinical scenario before you move forward. And then it brings us to the recommendation screen. And for this patient, the recommendation is a 1-year follow-up. So this is because the person's immediate CIN3+ risk is less than 4%, but their 5-year risk of CIN3+ is 3.60. So this falls into the 1-year return. So comparing this recommendation course to the clinical scenario prior, this patient we would invite to come back in a year for co-testing for surveillance, whereas the first patient without that known negative HPV would move on to colposcopy. So this is a nice way to kind of see this impact that we're going to see right away. We're hoping for lower risk patients. Again, we can avoid these procedures that really, per risk, are not indicated. We're going to do one more clinical scenario, and then if anyone has any questions, I'm happy to answer them. This time, again, a 36-year-old person presents after a colposcopy, so post-colposcopy, for their 1-year surveillance cervical cancer screening. So they had a prior cervical cancer screening result of ASCCP HPV positive, and then they went on to colposcopy. So this is pretty similar to the first scenario that we went through. They went on and they had a colposcopy, and the colposcopy resulted with CIN1. And this is a low-grade result, okay? They were told after colposcopy to come back in a year for follow-up surveillance. And that's what we have now. We have their current co-testing, cytology and HPV testing, and we have NILM. It's a normal PAP, but that HPV positive is a stinker and it's still positive. Okay. So again, what we're going to do is go back to our app to decide with our decision making, what is the best course of action? What surveillance is needed for this patient? So again, we place our age range. Clinical situation is a little bit different for this patient because this is management of results during post-colposcopy surveillance. So we can change the clinical situation as we are taking into account how best to treat or recommend therapy for this patient. We go on, and just as we did before, we input HPV positive, cytology normal, okay? Does the patient have previous results since colposcopy? No, we don't have any other previous results. We just have our current result today. But it does say for the colposcopy, what was the result? You can put in that it was completely normal or no CIN noted, histologically low grade L-cil-CIN1, which is what our patient had, or histologic H-cil-CIN2. And then some cytology prior to the colposcopy, kind of what got them to the colposcopy in the first place, and that cytology with ASCCP. Again, we go to that confirmation screen, make sure we hit all the right buttons, and then get to our recommendation screen. And our recommendation screen does share that co-testing in a year is what we need to invite our patient to do. So as far as immediate CIN3 plus risk, it is less than 4%. We do not meet a threshold to return back to colposcopy. Instead, we're looking at that 5-year risk of CIN3 plus, and it is surpassing the 3-year return. It is squarely in the 1-year return. And so we would invite our patient to come back in a year for surveillance. Like anything new, getting used to this is going to take a little bit of time. But we can say, even from these examples, that in compared to the 2012 guidelines, which would recommend colposcopy for this patient, colposcopy is now not indicated based on risk. So you can see how moving to risk-based from result-based will be a personalized management and move us forward into the future. I wish to thank all the groups listed on this slide. They're all marvelous and amazing, smart people. And to thank you for spending your time with me today. I hope that this was informative and provides a clearer background and understanding of the 2019 ASCCP risk-based consensus guidelines. And I wish you a safe and healthy 2021.
Thank you for that fantastic presentation. And thank you to everyone who attended today's session. Be sure to follow OHSU Family Medicine on Twitter at OHSU Family Med, all one word. Be sure to follow ASCCP on Twitter at ASCCP and learn more on this topic over on their website at asccp.org. Be sure to follow the Bridge C2 Center on Twitter at Bridge C2 Center, all one word. It's at Bridge, the letter C, the number 2, Center, and over at their website at bridgeinnovation.org. That's bridgeinnovation.org. And follow OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, be sure to head over to OCHIN.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And OCHIN Grand Rounds will return on Friday, February 12th with Dr. Jonathan Todd of OCHIN presenting on ECRA, or ECRA, Electronic Case Reporting Adoption by Health Departments. So from all of us at OCHIN and from Dr. Weiser to all of you out there, have a great rest of your week and stay healthy out there.